Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford and I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respects to elders past, present and emerging. This webinar will focus on fear of recurrence for women with ovarian cancer, and it will provide an overview of the I Conquer Fear program, an online program to help women affected by ovarian cancer manage their concerns about fear of cancer recurrence and/or progression. We're extremely grateful for the funding received from AstraZeneca for this webinar. The webinar is interactive, so over the next hour you can ask questions to the presenters by using the dark blue hand icon at the top of your screen. Questions will be answered at the end of each speaker's presentation. Please note that presenters cannot address individual medical cases. If you have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. For technical assistance during this webinar, please phone Redback Support on 1800 733 416. So I'm privileged to introduce our speakers to you. Our first speaker is Associate Professor Lisa Beatty, an Associate Professor in Clinical Psychology at Flinders University and a visiting consulting clinical psychologist at the Flinders Centre for Innovation in Cancer. Lisa will provide an overview of fear of recurrence and discuss some strategies to help manage it. Our second speaker is Dr. Ben Smith, who is leading a team collaborating with OCA to trial I Conquer Fear. Ben will outline how I Conquer Fear may help people get less caught up with worries about cancer coming back or progressing, and some of the benefits that the program has shown to date. We will then hear from Victoria Turner, who was diagnosed with stage 3C high-grade serous ovarian cancer in 2020. Victoria will share her personal experience when it comes to fear of recurrence, and will talk about how she copes and manages this fear. So I'd now like to hand over to Associate Professor Lisa Beatty. Thank you, Lisa.
Thank you. Okay, I'm really pleased to be invited to present today on fear of recurrence. I guess my role today is to just give a really broad overview of what it is and how it might present in clinic. Okay, so just to get started with, I thought I'd start with the established definition of what fear of cancer recurrence is. And it was defined by LaBelle and colleagues back in 2016 following a big consensus piece of work that they did as the fear, worry or concern relating to the possibility that cancer will come back or progress. Now, why is it a problem? A lot of people might think, well, everyone who's gone through cancer would be reasonably expected to experience fear of recurrence. And yeah, the stats do show that up to 73% of cancer survivors will have some degree of fear of cancer recurrence. However, I guess while it is a universally experienced concern to some degree and can have positive benefits in terms of potentially motivating some health behaviours, engaging in routine checks and recommended follow-ups, there can also be some real negatives in terms of being strongly associated with depression, anxiety, generalised anxiety. It can be chronic and disabling and increase healthcare costs as people may actually request additional healthcare visits and checks outside of what's routinely recommended. And I think perhaps most critically is that we know that it doesn't reduce without intervention for those who are experiencing really significant fear of cancer recurrence. Some of the early reports that first came out indicated that 49% reported what would be considered moderate to high fear of cancer recurrence. And these are the people who are at higher risk of these negative outcomes. So in terms of some of the research that's looked at categorising fear of recurrence, some of the measures that are one of the most commonly utilised measures is called the Fear of Cancer Recurrence Inventory. And when you look at the severity scale of this, there are different cutoffs that have been developed over time. One of the first cutoffs that was developed was a cutoff of 13 plus. And that's sort of more of an indicator or an initial screen that suggests that people may be at risk of fear of recurrence. And as you can see from this graph, this is the bottom line here. Would show that nearly 60% of people would screen as being potentially at risk for having fear of recurrence. However, two other cutoffs have been proposed of 16 and 22, and perhaps more recently the score of 22 or above on the fear of cancer recurrence inventory is really showing to be quite sensitive and specific to more that clinical level of debilitating concerns of clinical fear of cancer recurrence. And that shows that it's quite close to around 20%. So 1 in 5 people after they've been diagnosed with cancer will experience these really quite challenging and significant levels of fear. And this data has come from a big meta-analysis of 46 studies of over 11,000 participants from around the world, and also shows that the people who are potentially most at risk of experiencing this fear are younger people and also women. So I guess one of the key things then is, what do we mean when we're talking about clinical fear of cancer recurrence? Well, in the original definition and work that was done by LaBelle and colleagues, there were 5 key features that were proposed that would really characterise what would be kind of differentiate what's more normal or what everyone experiences in terms of some passing fears and ideas of the cancer may be coming back, from more what we mean by this debilitating or really impactful clinical fear of recurrence. The first of these is that there would be high levels of really preoccupation or worry and rumination or intrusive thoughts. So things that having thoughts and images and memories and ideas about the cancer that just can't easily turn out of someone's mind. This is then accompanied by some maladaptive coping strategies, and that would include things like the tendency to avoid reminders or avoid thinking about or avoid engaging in behaviours such as your checkups and things, or also in things like engaging in a lot of reassurance seeking, so feeling quite concerned about the cancer coming back and then actually going and asking for a lot of reassurance from family or friends or additional health checks, like additional appointments, to get that reassurance that the cancer hasn't come back. And one of the key things that can sometimes come up is this body checking, the idea that if I scan my body, I might pick up on the cancer at the first possible sign of it recurring. But the more we check and the more we poke and prod, the more likely it is that there might be some quite benign symptoms there that are then interpreted as being a sign of the cancer coming back. The third category or key feature of this clinical fear of recurrence is around functional impairments. So we're not talking, I think as what I started out by saying, everyone might experience some of these fears from time to time, but when these fears are getting to the point where they're causing interference in your ability to do your day-to-day activities, so it's impacting your ability to do your work, it might be impacting on some of your relationships, that's when we'd be saying it's starting to have a little bit more at that clinical end of things. And it may also be that it's causing excessive distress. So even if you're able to still go to work and do your day-to-day activities, but you're finding it's causing really significant distress and disruption for you, and you're finding it's really affecting your joy for life, that's another sign. And one of the last key features in this original definition was around the idea that it was difficult to make plans for the future, that some people might find that they're just not really seeing the point in making plans for the future because the cancer is going to come back and disrupt it anyway. So they feel quite paralysed about making plans for the future. Now, in 2020, there was an international study that provided a little bit of an update to these features, and really it was more about fleshing out the first of those, first and second categories of the original one, in terms of saying that it really is characterised by those high levels of preoccupation, that it's dominating thinking and really causing high levels of worry. And this needs to be persistent. It can't just be something that comes and goes or is fleeting. It needs to be persistently there for over 3 months. And that hypervigilance, that real awareness and constant scanning and checking of body symptoms is one of the key factors that we'd be expecting to see. So I guess that's all good and well to hear about it in terms of a checklist of things to look out for, but I thought I'd give a couple of case scenarios of what that might look like if you're in clinic or if you're presenting to clinic. So I've got 2 examples here. First of all, we have Jane. Jane is a 44-year-old married cisgender female with 2 daughters, ages 7 and 10, who was diagnosed with early-stage ovarian cancer 18 months ago. She stopped working as a childcare centre educator during her treatment and has not yet been able to return to work. Jane reports that she got through her medical treatment like a breeze, with everyone telling her how strong she was. However, since completing her chemotherapy 6 months ago, she's been finding it very difficult to get back to normal. Now, Jane presents as frequently tearful and agitated, and she states that she thinks she's going crazy as she can't stop thinking about her cancer coming back despite doing everything she can to put it out of her mind, including not using the term or the word cancer. In fact, Jane requests that you please don't use the word cancer in your sessions with her as she finds it confronting. Jane avoids reminders of cancer where possible, including changing the route that she drives to avoid passing the hospital where she had her treatment. She avoids cancer-related adverts on television. She avoids talking about her cancer with her family and friends. Yet despite all of these efforts, Jane knows that she still just can't stop thinking about the possibility her cancer will return, stating that she wouldn't cope and fearing how would the girls cope and that she'll leave them motherless. Jane is extremely sure, very, very sure that her cancer will come back and estimates that the probability of it coming back is about 90%. And that should be noted that even though that would not necessarily be the rating or the realistic probability that her oncologist or her treating team would be giving in the same, based on her active stage of cancer. And that she also believes that her stress or her worry may actually cause the recurrence, or at least make it more likely or more severe. Jane tries to minimise her risk by attending all of her scheduled appointments, and she also presents promptly to her GP at the first signs of bloating, pain or heightened fatigue. So this may look like someone you know. You may have experienced this yourself. This is kind of a combination of people that I've worked with that I've put together here, and some of the key things that we'd be looking out for as a psychologist. It hasn't really come up as well in this, but I've tried to highlight some of the things that really we're looking for here in terms of, the impact that it's having. We can see that she hasn't returned to work, even perhaps though she may have actually been cleared by her oncologist to do so. So this is actually more her worry and her concern around the fear of recurrence that's really impacting on her ability to return to work. It's been quite enduring in terms of it's been lasting for 6 months. And it's causing significant distress in terms of causing tearfulness, agitation. The worry is really, quite preoccupying for her and severe in terms of feeling like she's going crazy with it and not able to put it out of her mind. She's also using a lot of avoidance strategies here, and we can see that although in the short term they may help to her to not think about the cancer, it's actually keeping her stuck in this. The more you try and not think about something, the more it kind of demands attention. So there is a lot of, paradoxically, the more that she's avoiding in terms of even the places that she drives is actually in turn feeding back in and feeding that anxiety for her. And as you can also see, there is actually some signs there that she's doing some body checking and potentially also engaging in more healthcare service use than would necessarily be recommended by presenting to her GP really frequently. So that's one example where perhaps you're seeing a little bit more of the avoidance side of things, and also combined with a lot of the body checking. What would be another example? Well, this time we've got Josie, and she is a 69-year-old widow who was diagnosed with stage 2A ovarian cancer in 2019. She completed all her treatments in 2020, including a hysterectomy and a bilateral salpingo-oophorectomy and chemoradiotherapy. Now, the treatment caused a lot of side effects, including nausea and reduced appetite, along with severe fatigue. Josie's daughter, Maria, attended all of her appointments with her, as Josie doesn't drive and she lives alone. Now, Maria actually attends the appointment with you, the psychologist as well, and notes that since completing the treatment 2.5 years ago, Josie has talked constantly to me about when it will come back, and that Maria tries to provide reassurance, saying that of course it won't come back, that they got it all, but Maria knows that this reassurance doesn't seem to help all that much as Josie continues to worry, and if anything, she's worrying more with the passage of time. Josie's getting to the point now that she's quite concerned that Maria, her daughter, is getting fed up with her. She also says to you that she's aware that she's now halfway through her magical 5-year survival mark, and if anything, instead of viewing this as a good thing, she's now thinking it's actually more like she's into the latter 2.5 years and it's a countdown timer for her. So again, viewing it more as an inevitability that it will come back within that 5-year window. Josie has reduced her activity since her cancer diagnosis and is no longer volunteering at Meals on Wheels, as she wouldn't want to cause any disruption to the rostering team when her cancer comes back. Josie finds that her routine checkups extremely distressing and experiences what we often call, and she was calling, scanxiety each time. Josie thinks that if she keeps focusing on what she'll do if her cancer comes back and keeps talking it through, then she'll be prepared for it. However, Maria thinks that this might actually be impacting Josie's quality of life. So we can see from this example, and again, I've tried to highlight here, but the colours haven't quite shown up. I guess some of a slightly different presentation where instead of trying to avoid talking or thinking about it, we've got someone who's trying to cope by talking about it and thinking about it constantly and thinking that that will help them prepare and get ahead of it in some ways. But conversely, interestingly, this strategy, although it's the opposite to what Jane was doing, also actually keeps feeding into that, that cycle of anxiety, because the more you think and talk about it, you just can't carve out any time away from the cancer. Again, you can see that it's been quite enduring in this case. And it also shows that why for some people, the passage of time doesn't actually help. That if anything, it can almost feed into that, that fear of recurrence, because it is that countdown time mentality. We can also see it's having an impact in terms of her ability to engage in her normal activities as she's no longer volunteering. And I think it's also worth noting that for someone like Josie, we would also be wanting to factor in the isolation, the fact that she is widowed and living alone, and that might actually be increasing her vulnerability and her likelihood and her risk of actually experiencing this quite significant fear. So there's just two little examples, I guess, and these are drawn from people that I have worked with over time, you know, a combination of people, to really highlight, you know, some of the things that people talk through and how it looks in real life with people that we're working with. And I guess in terms of how we go about then treating this, there are a number of evidence-based therapies that have been developed, and of those, cognitive behaviour therapy does have the strongest evidence base. And recent systematic reviews show that psychological therapies that focus more on the process of thinking are actually more effective than what we're thinking. And what I mean by that is, instead of challenging the content of a thought, so for example, Josie's thought of there's no point in volunteering, instead, contemporary therapies will teach skills in recognising that you've been caught up in that story again, that you've been caught up in rumination, in that tendency to just think and unable to stop thinking about it. And then in turn to learn strategies about how to unhook yourself and pay those thoughts less attention. They're allowed to be there in the background, but they don't need to be the thing that you keep focusing in on. Combined with some behavioural strategies to reduce some of that reassurance seeking or to challenge that avoidance and body checking to levels that would be more commensurate with what medical professionals would be recommending. But you'll be hearing more about those particular treatment strategies in the next talk with Ben. Now, these treatments that have been developed over time can be delivered in different formats. Some of them have been delivered in individual therapy, and that's probably where the majority of the work that I've done has been in terms of delivering one-on-one therapy. Some other studies have also looked at delivering these sorts of programs in groups, and you can imagine the benefits there that you're hearing about how other people might be coping as well, and when one person experiences success, it can be really powerful to hear about that from other people who are going through it as well. But the challenge, I guess, of both individual and group therapies are that they're quite resource intensive to deliver, requiring a really specialised workforce that's been upskilled specifically to do that. And that workforce can be, we just don't have that many of them. So it's a small workforce and there's a really large demand. So I know that more recently we've been looking at online modalities for delivering and scaling up these sorts of programs. And I think one of the more recent pushes as well has been to look at what we call blended therapy, where it's a combination of potentially individual therapy with some online components as well. So there's some of the different options out there. Now, just a quick note about the definition. I just wanted to note that, as we said, that the fear of cancer recurrence as defined also includes, in the last two words there, progression. And everything we've talked about so far have been about people who've been treated with perhaps an earlier stage cancer where we're much more focused on it recurring. But what about for people who potentially have a more advanced disease or potentially metastatic disease. Or then there's the term fear of progression. Now, the exact wording of the definition originally was debated and chosen carefully to encompass fear of progression, to reflect the fact that they were viewed as identical constructs. However, at the time, it was recognised that additional research was needed to examine how the phenomenon of fear of recurrence might differ for those who have a curable disease with a fear of recurrence versus those who have incurable disease and are living with a fear of progression of their illness. And indeed, since then, some of the research has come out that shows that although they're very much related, there are actually different predictors and different factors that load onto these constructs. So they are actually quite distinct, very much related, as I said, but quite distinct. And so with that in mind, it is necessary to ensure that in clinical practice and research that these constructs are actually considered separately. Now, I guess one of the good things to note, though, is that the same kinds of interventions are demonstrating some promise looking at and treating fear of progression as well as fear of recurrence. And in Australia, where there have been some stepped care or programs for those who have responded to immunotherapy. There's been some online booklets that have been developed. There's been nurse-led interventions that have been trialled as well. And these are all pilot studies that, and they're all demonstrating that there might actually be some real promise for programs based on that contemporary style cognitive behaviour therapy in really helping with fear of progression as well as fear of recurrence. But the challenge is, as we've already said, that these programs, when they're delivered via the specialist psycho-oncology workforce, is that there's just not many of us. So we need to develop brief interventions that are scalable to try and help manage the demand to support both fear of recurrence and fear of progression. And the internet-delivered approaches would be an obvious first step. So I'm going to leave it there because I think that's a nice way to segue into Ben's talk. But if anyone has any questions, I think that's me done.
Thank you so much, Lisa, for all that valuable information. We do just have a couple of questions that have come up. One of the goals you listed for Josie was to help her reduce how often she seeks reassurance. Why is that?
Yeah, so as I kind of hinted at, we actually know it's one of those things that might sound a little bit paradoxical that, you know, by getting reassurance, you'd think that would make someone feel better. But I think most of us can also relate at times, whether it's about fear of recurrence or anything that's making us feel anxious. When you ask for reassurance, yeah, it does help in the short term, but actually all it ends up doing is keeping your mind focused on the very thing that you're anxious about. So yeah, it might help in the short term, but it actually ends up just perpetuating it in the long term.
Fantastic. Thank you so much. We'll leave it there. Thank you so much again for your time, Lisa. Really appreciate it.
No worries. Thank you.
We also just had one comment come up just as Lisa finished. So hopefully Lisa's still online and I can put this to her. Someone's written, I've experienced a recurrence 2.5 years after first diagnosis. Nothing showed up in regular blood tests and screening. I had very slight discomfort. I pursued the screening and eventually a tumour the size of a mandarin was discovered. I was commended for pursuing it. I'm not particularly stressed, but very aware of checking regularly. So I kind of think that pursuing it saved the day. Lisa, did you just want to comment on that, please?
Yeah, for sure. I think that's just another point to clarify that we're certainly not recommending or advocating that people sit and ignore symptoms. It's just more about how to live with the worry that comes up while you're waiting to find out what happens with them, and also around making decisions around not jumping on every symptom the second it starts. So it's about, you know, working out how long can you sit with a symptom to follow those medical recommendations, and then how do you manage the anxiety that comes up while you're actually waiting to see whether the symptom needs to be followed up or not. So it's finding that balancing act between not wanting to get every single symptom checked, because it can end up being a bit like a radar that's picking up a lot of white noise and not always picking up what we really need to focus on, but at the same time not sitting too long on symptoms. So it is finding kind of that balance between them. But as I say, the most important thing is around for these programs is around how to live with the anxiety that comes up while you're you're navigating those symptoms.
Thank you very much, Lisa.